need, then you will see that communicable diseases till COVID came up was on decline. But road traffic injuries, non-communicable diseases are all increased. But one thing which will dictate the health sector response in 21st century is aging and age-related issues. So I'll talk about COVID later and how COVID disrupted everything, what we planned. But
Now
we
it's
keep
clear.
in mind that most of our health sector response in 21st century will evolve or revolve around aging issues. So demography is changing, means in early last century, people used to die between 50 and 60 on average. But this century, people are living even beyond 100. But as we live longer, we all gradually experience functional decline. And that functional decline doesn't happen in single functional domain. It happens gradually in more than one or in all functional domains as we age. So the health sector response cannot be like what it was before. Okay, he's paraplegic, only spinal cord, or with blindness or deafness. So respective area is mostly affected by single functional domain. But with aging, we are living the era of comorbidity, and we'll have a more functional domains which will be affected due to the aging. So we have to be more multitask people than the single specialized people of the last century. So 21st century is all about aging and disability. People living longer everywhere, even in India, even in low middle income countries. As we grow older, all of us will experience disability. It is no more about others, it's about all of us. Some will experience disability since birth, some will experience at an early age, but majority will experience it as they grow older. Aging and gradual functional decline are almost synonyms. No medicines or vaccine can stop it or reverse it. We also see a lot of demographic change in the environment we live in. By 2050, 33%, one third of the world population will be either older people or disabled people. An emerging aging population will blur the divide between disabled and non-disabled. You will not know in next 10, 20 years time who is disabled and who is non-disabled. Today, more people living in urban areas than rural areas. So working and productive people in urban areas and old grandmothers, maybe with the grandchildren, are in the villages, which is creating another challenge for the health sector response. Average family size is shrinking. When we were young, we saw poster everywhere, small family, happy family. But as we are living longer, with longer lifespan, now we are looking at old age home, new family, family of unknowns. So it's quite challenging in terms of the health sector response. So if you look at the 21st century major drivers of disability and rehabilitation, the main causes of polio, childhood blindness, deafness, these are all the stories of the past. There will be more, we'll have children more with a cerebral palsy, congenital, or autism like that. Young more with the spinal cord injuries or amputees, mostly road traffic injuries. But huge population will be more resulted in the aging, especially stroke and diabetes. So our health sector response will be, we have to really shift our focus attention as the demography of the disability and the population is changing. So major drivers of 21st century healthcare would be aging, I focus again, aging, non-communicable disease, and disability. And if you look at the slide in between and the photo image, the lady has diabetes, but she lost her leg. She has a vision problem. She has a hearing problem. So it's no more only about insulin or blood sugar. It's also about mobility, vision, hearing. So it's a multi-functional domain issue. So, and the one thing is people before, if they had NCD, they have a chronic health condition, they used to die early. But now, even with those chronic health conditions, they're living and living longer. So the issue is coming now, not only the cure, is also about quality of life, well-being, independence. So now the question comes, does 20th century health service delivery model is good for 21st century? And same 20th century competency of allied healthcare professionals, is it good enough for 21st century? And then COVID came, which derailed all our thinking, and it brought completely new challenges, and it really exposed us that how weak we are, how backward we are in terms of the health sector response. Take an example of hearing aid. If somebody needs a hearing aid, usually they go to a medical doctor, then it goes to ENT, then goes to audiologist, then go to ear mold technicians. In the same way, there is a developer, manufacturer, distributor, retailer, supplier. So all these chains, all these tiers actually increase the cost of the healthcare service provision. We have to also ask ourselves whether childhood hearing loss and age-related hearing loss are the same. Do they have to go through the same process? So these are the questions and the real competency challenges now coming to the health service delivery and also health sector personnel who will be responsible for such services. Now, if we ask people, how do you define healthcare? Most people will say, is it preventive, promotive, curative, and rehabilitative? That's how we have been taught. That's how we have been taught in 1978 Alma Ata. So in 21st century, recently they have added palliative care. But there is a big gap between curative and palliative, rehabilitative and palliative. More and more people live longer between this curative and palliative, or between this rehabilitative and palliative phase, where they need support, they need assistive support. So 21st century healthcare definition should be beyond business as usual. It should be preventive, promotive, curative, rehabilitative, assistive, and palliative. So assistive care will become a big subject in the 21st century health sector response. Now, how we define assistive care? The image on the left talks a lot. The man is taking his older mother to the shopping. She has a walker, but still she needs some support. So is a human and technology. So how human and technological assistance can be provided to assist a person to do what she or he wishes to do, even after significant declines in physical and mental capacity. And assistive care includes assistive technology which enables and promotes inclusion and participation, especially of persons with disability, aging population, people living with non-communicable diseases and other conditions, chronic conditions. Assistive care needs to be considered as essential health services, especially for people who live independently in the community or home. So today, more than 1 billion people, or more than 2 billion by 2050, will need assistive technology. But only 10% have access to assistive technology. So for this, to address this big challenge, WHO, World Health Organization, on 4th July 2014, established a GATE initiative, Global Cooperation on Assistive Technology, to promote the concept of assistive care and assistive technology worldwide. And in 6 years, like many of you know, we have an essential medicines list, essential diagnostics list. WHO also published essential priority assistive products list. We published global priority research agenda and policy, how a country should develop their assistive technology program. For health personnel, we developed a lot of training programs, guidelines, standards, from wheelchair, hearing aids, prosthetics, and orthotics. Many of prosthetic orthotics training program around the world is based on WHO's guidance and the standards defined for the prosthetics and orthotics community. We are happy that Rajiv Gandhi University also runs a program with Mobility India, and WHO has a full support for such programs. And we hope that in future, Rajiv Gandhi University will also consider starting a postgraduate program in assistive technology. Currently, all assistive technology programs only exist in North America or high-income countries in Europe. So this is a great new opportunity for future to consider about. In 6 years of GATE, we also created some kind of a global partnership, 80 scale, 80, 20, 30. We are in the market shaping of the eyeglasses, hearing aid, wheelchair, prosthesis, and tablets. We're really trying to revolutionize the whole assistive technology sector. We are very sure by next decade, the blind people don't need to learn Braille anymore. With the tablet, with the digital sign language, many people will be in the mainstream school from the day one, and they don't have to learn they don't have to use special tools to compensate their functional deficiency or disability or impairment. So we have, the problem is many people do not know how many people need assistive technology. And common perception is that assistive technology is for disabled people. So WHO has developed a mobile phone based or tablet based quick software apps to identify what's the need, what's the demand and supply. And in one of India's neighboring country, when we did this piloting of this tool, the government statistics says 2% people needs assistive devices from their disability statistics. Then with the model disability survey using the Washington City Group question, they said 10%. But when we really used this app, we really went to every household and tried to find out all the people need assistive products, especially the elderly people. We got 22% population in need of assistive products. So 2% to 22%, and that is hidden. This 20% is hidden, which we are trying to say, look, these people need these products. And these people needs to be addressed. So we talk about AT ecosystem and AT service provision. So we talk about 5 P, people-centered policy, products, personnel, and provision within the universal health coverage, and try to see how AT provision can be done within the universal health coverage, making universal health coverage as inclusive, and trying to see that all services are developed, are provided from one place. So people doesn't have to go for hearing one place, vision one place, for wheelchair one place, prosthesis one place. So all these basic essential services are available in one place, that one-stop AT center. That's what we are talking about. Now coming to COVID. COVID really added more misery, especially to the rehabilitative and assistive care in new normal. In the image on the right, this is where Wuhan, China, the national hospital, and where the rehabilitation facilities or prosthetics and orthotic centers are in the 15th floor of the building. Or Mobility India, what we have seen, but all these facilities were closed down during the COVID. So the people who needed service, even for simple repair, they were stuck again. So disabled became able, but again became disabled because of lack of service. So we have to really understand how we can ensure that uninterrupted service even when this kind of scenario happens. And if you see the implications in the context of COVID-19, and if you read this WHO latest policy document, that rehabilitation and long-term care facilities in most countries have experienced most difficulties. Personal assistive care needs to be provided in close proximity. You cannot do it from remote everything. But for doing that, you need to maintain physical distancing. So all these are bringing new challenges to us to provide the services. So how the people address these issues in the past, and then we saw learning from the past. So many people went for telemedicine, and the fundamentals of telemedicine is that how you can provide remote service. So from hospital to home or community-based care, when making best use of ICT. But WHO now has created a new department on digital health, where we are trying to see how we can ensure most of the health services, health education, everything can evolve around digital health. So this is our director said, what we call digital health today will be in future known simply as the way we deliver health services in the digital age. So all the competencies of the healthcare professional has to now become more digitized or based on the digital health. We also learn a lot of community-based rehabilitation, how we can do this using the community. But COVID has challenged that theory also, because even people could not access these services from the community-based services. So we are trying to see how we can go one step further to go to the people's home using a blend of CBR and ICT. So if you look at these images across the world, you always see that there's an user and then their family members. Professionals are there, but professionals are there for some time. Professionals are not there for the whole time. But the family members are with the family, with the person all the time. And we neglected these family members could be a great human resource who can share the responsibility and some tasks of the professionals. So now what we are trying to see, on one hand, how to take advantage of the digital technology, cloud-based service, 3D printing, robots, drone, and at the same time, how to make best use of the available human resources, especially the family members, to ensure the services do not get uninterrupted and people can get the services. So this is how WHO during the COVID or post-COVID is our next initiative is Stellarity. So how we can ensure AT is available, rehab services is available at home. So optimum use of technology and available human resources to provide and maintain assistive technology at home. This service is not one-time affair. Physiotherapy is not one-time affair. It has to be continued. And it has to be continued with the support from remotely, but at home, and where family members can do a lot of task sharing job. So what is the difference between telehealth and tele-AT? We're trying to see the mid-tech professionals become more made and technology savvy. So they become more familiar with the technology, digitization, and digital health. And then they support remotely with the help of the family members, caregivers, and peers to person disabled and older people or NCD people, so that you can reach more people at a quicker time from a small location, and you can be more useful. That's what we are trying to see. So some key features is improving access, leaving no one behind, making optimum use of technology. Technology, when I see usually people focus on the mobile or computer, but we are going beyond, more cloud-based services, artificial intelligence, 3D printing, how artificial intelligence can help, or how you can help artificial intelligence to give more services to the people. So here we are counting the competencies of the healthcare professionals. So tell us how you can influence the artificial intelligence, how you can influence the 3D printing, so the more people can get the benefits than what people are getting, number of people are getting today. So influencing allied and healthcare professionals to embrace more digital telehealth, tele-rehab, tele-AT mode. So service from hospital centers to home. It's like home delivery. Everybody do not go anymore to pizza house to get the pizza. They have a pizza delivered at home and they like it, they enjoy it. So why cannot we do the same for assistive technology or rehab services? So task shifting, sharing from professionals to the users and family members is a key component. And creating local centers and facilities. We like Indian Prime Minister, what he said, vocal for local. And that's the answer. So develop local capacity, develop local business, local support system, because local are always there. So if you are interested to know more about our work, to be more associated with us, please join WHO GATE community. And here is the link. More than 1,500 organizations and individual professionals are our member from 114 countries. We'd be very happy because we depend quite a lot in India, because we think India can really play a significant role in changing the people's life in India and the world. So with this, available for any question and answer. Thank you very much.
Thank you, sir. That was very informative. And I just have a question. I was very interested in what you told. Are we looking at a convergence or something like that? A single platform to perform multiple tasks in the future for assistive technology?
Yes, sir. Especially we are looking at that, and we'll promote that from WHO significantly. And we are also developing a training programs to help the healthcare professional as well as the users to provide these services from the single source. And we're also investing in the artificial intelligence, so where the professionals from different countries will support to provide the services, because it will be difficult to get people with all skills tomorrow to provide services at one point. So, so we are developing this kind of a support mechanism to ensure that convergence takes place and all essential services are available from single source, and that too preferably from the district hospitals or primary healthcare centers.
Thank you, sir. Any other questions? Anybody? You can please
Mr.
unmute.
Mr. Kasnabis, I mean, that's a very informative lecture. Thanks for the various dimensions of treatment available for health that represent. We have not only the preventive, promotive, curative aspects, but the 21st century is all about rehabilitative, assistive, and palliative care as well. So I think these professions are still in its infancy. We need to give a lot of boost and a lot of encouragement to see that these become established, and more youngsters would take up these courses. I think Rajiv Gandhi University of Health Sciences, we already started these courses in Mobility India and a few other places, and we are also trying to establish master courses and also PhD as well. So that sort of a boost should be given everywhere. And then only think probably people will also be aware of it. And then more and more people will, utilize the services given by assistive technology and then benefit out of it. I think that should be the, focus right now. Thank you so much for your, wonderful lecture. Thank you.
Any
Thank
questions?
you very much. And if Rajiv Gandhi University wants to do that, you think about us, you're not alone. We'll be very happy to support you, to collaborate with you, to establish
Absolutely.
habits. Okay?
Absolutely, sir. That's very nice of you. Thank you.
That's the future.
Yes, any other questions? Sir, evidence-based research, are we looking at an evidence-based design concept?
Absolutely. We are looking at both evidence-based design concept and also users' participation. The many times people do not consider or consult the users in the design process. So we need one hand the evidence. We also have to understand what is happening in the mainstream technology development, especially material science, and at the same time users engagement, because sometimes people develop a product, very good product, but users find it is not applicable. So the users participation and evidence and the knowledge of the available, all these three is the key elements to ensure that innovation comes to the market, because there are many innovation takes place, many innovative idea comes up, but it doesn't come that proportionately in the market. And that's what we need to really invest more in that area.
Maybe when we are looking at this, I think in future, we are also forcing a possibility of portability and interoperability also.
Sure, absolutely. Because otherwise it will not work. I give you a simple example. Many things what I said will not work in the emergency situation. Many products we support, develop, we cannot deliver that in the emergency response. So we have to have those kind of a flexibility, possibilities, opportunities for different situation or different demand, different context. So yeah, that's very essential too.
Thank you, sir. We have a question from Purushottam Dantala. He is asking, can WHO provide helpline number in this COVID time for assistive technology?
The thing is, WHO doesn't have a special program only on assistive technologies, more for the COVID in general. And WHO country office, the thing is, WHO is not a service provider. WHO supports the member states to provide the services, to ensure that member states, whatever support is needed, not to interrupt any services, right? So I'm sure the Ministry of Health or Ministry of Social Justice in India government has those kind of a helpline. But if they need something additional input from WHO definitely would consider, provided the request comes from the line ministry.
Thank you, sir. Any other questions?
Yeah, I have a question. Sir, you talk about that we need to move from conventional mode of services, rehab services or assistive technology services or health services into more into digital mode. So what I would like to ask that how cost effective it is, or is it cost effective, or how can it be made cost effective?
That's the answer. You have to make it cost effective. Cost is very related terms. Cost, every time I go to buy a TV in Geneva, I get a better TV at a lower price than the last time. So, and how is that is happening? Because the number of consumers is increasing. So suppose a physiotherapist from a center provide physiotherapy to people, at the most they can provide services to 10 to 20 people. And each services, if I say cost $10, so that means he output generates $200 at the most in a day. But if you can ensure that instead of these 10 or 20 people, the same physiotherapist gives services to 200 people through remote or 2,000 people, the cost will be much, much lesser. See, the countries like high income countries, I am talking about Australia, New Zealand, Norway, they are now going in this mode because they also see that need is increasing, the healthcare cost is increasing, but health budget is not increasing that proportionately. So when the need is increasing, and I don't think even in India, the healthcare personnel number, healthcare budget is increasing proportionately as the need is increasing. So the only way is that how we can, with the similar input, how we can give more services to more people, and that way we can bring the cost down. So if investing in heavy machineries, equipment in a rehab center, can you do something more portable, smaller, simpler devices at people's home so that people can use it with your support from the center? So we have to really, it has to start from and these things has to start from the training center. Training center also has to innovate and make sure that all the classes are not face-to-face learning, face-to-face practical demonstration and all this. So it has to start from the training place, that how we can make best use of digital services and other technologies to ensure that we can reach more people. And if we can reach more people, cost will come down.
Thank you, sir.
We have one more question from our participant. How can we ensure assistive technology reaches to the rural parts?
It's a very good question, and that's what we have to ensure, that it has to be mainstreamed. The thing is, many places the assistive technology, rehabilitative care, palliative care has been treated as a specialized care for specialized group of people. And that's why these are not gone into the rural areas. And not even many district hospitals. So it is more in that part of the tertiary care. So we have to really see that how it is part of the primary health care or community health care services. That doesn't mean all the services has to be there, but some basic essential services has to be there. And then only it will reach to the rural people. And that's what work we are trying to do now, that how to integrate assistive technology provision in the primary healthcare and community healthcare, we have come with a package of 27 products, which can be given at the primary healthcare level with the minimum support or with the minimum training of the primary healthcare personnel, especially the nurses. So these are the different approaches. But if you have to go to the rural areas, then you have to see where rural areas people go for their healthcare services. Is that local hospital, primary healthcare, community healthcare services? And if rehabilitation, if the assistive technology services are not part of those services, it will never reach to the rural people. It will never available in the rural areas. So we have to really start from there. And that's what we are trying. And if you look at the WHO's program of work, is one of the key, our target is that making these services available at the primary healthcare.
Next question we have from Dr. Sundar, Ramaya Medical College. We have reasonably large number of therapists. How can we leverage their skills in improving access to assistive technology?
That's a good question, and I'm very thrilled to listen this. The thing is, one, you can do a crash course, and another way is that getting AT as a module in the course curriculum. See, now if you want to be an AT expert, as far as you have to correct me, as far as my knowledge goes, there's no training, AT related training exists in India. So people have to do the training in Canada or USA, in North America, in Resna or something, which to me is bizarre. I don't find any reason why an Indian has to spend dollars to learn AT in America. Their culture, their technology, their insurance system is much different than what India has or the subcontinent has. So I hope as more people will get aware that one day this will become a part of the course curriculum and part of some kind of a postgraduate diploma or degree program. And then there will be, because we look at physiotherapy, occupational therapy, speech therapy, prosthetic orthotics people, because we don't have AT professionals. So they are our starting point. But we hope these professionals, but when we talk to these professionals, many of these professionals has no clue about beyond their particular field of expertise. And also the training in the course curriculum, if you look at the course curriculum, it's very much still centered around child and young, not that much elderly people. Many centers I see when we do not know how to talk to elderly people, how the services has to be redesigned to suit the need of the elderly people. And the physiotherapist and occupational therapist in particular are in the pole position to do all this, because in many countries where, for example, in Norway, where 100% access guaranteed for assistive technology, most services are provided by the physiotherapist, occupational therapist, or prosthetist, or the nurses. These are the four professionals from capital to the rural area, village. These are the four professionals who provide assistive technology. But all have gone through the training. So I'm sure you can think of some kind of model to introduce in your course curriculum.
Yeah, I was just, when you told these things, I was just thinking whether we can have, because we have a lot of physiotherapists who are already graduated and are working, can we have some special course designed for them in assistive technology so that we can have a lot of people who can work in the field of assistive technology, where we can get some content vetted by WHO or something, and Rajiv Gandhi University can offer it in affiliated colleges?
Yeah, everything is possible. And that's, I think, also a new market. It's a new market. When I talk to the World Federation of Occupational Therapy, World Council of Physiotherapy, this is a new market. And, people need service, and people do not mind to pay for services if they get a quality services at their benefit, at their choice. So as we grow, as we will go more towards 2030, you will see the whole health sector delivery response will change drastically. Because I have seen, even in my families in India, I have seen how the people, even they have the money, but they are suffering because they don't have the technology. My father was in a bed, and when I landed in Calcutta, he had 4 bed sores. So physiotherapists or other nurses, they were taking care of him, but nobody knew how to do the better positioning, taking care of bed sores, or in case of bed sores, how to get rid of bed sores. So when my father died, eventually, I repaired all the bed sores. So he didn't have any infection, nothing and all. So this simple technology, this is not rocket science. And you don't have to be at the bedside to do it. I do a lot of things from Geneva to my brother-in-law had a stroke. He developed hemiplegia. And I told him what to do from Geneva, and he cured 99%. So these are the things what I think you have to really see, and they will be happy to pay for it. I'm not sure. So this is a new market, new opportunity for the therapist. They have to really look at it, not traditional, those what we learned in our school 20, 30 years ago.
Interesting and encouraging, sir. We will come back to you regarding starting of some add-on courses for physiotherapists in assistive technology. I'm sure our Vice Chancellor will be very keen to take it up and start some of the programs. Next question we have is from Savita Ravindra from MS Ramaya College of Physiotherapy. Can WHO support us in putting the AT module in our course content at the undergraduate level? We would work through our university. Is it beyond undergraduate learning?
The thing is, if the university wants to do anything, best thing is write to WHO country office and with a copy to the regional office, and let's start the dialogue. And once that initial process is cleared, then everything is possible. Okay, so my suggestion would be that if Rajiv Gandhi University wants to be the pioneer or the champion of promoting assistive technology competencies in India, then think about it. We can give you the contact details of the people to address, and you have the full license to approach them. And we'll then find a way to how to do this together. We are part of you. WHO will not exist if there is no India supporting WHO, right? So don't think that we are outside another planet. So we are together, and together we can solve this and we can do it.
Thank you, sir. The next question we have is from Pearl. We have a lot of osteoarthritis of hip and knee ending up with surgical intervention. How assistive technology can prevent and play an important role in preventing arthritis in early part of their life?
See, there is 2 issues here. One is or 3 issues, I can say. One is the lifestyle. Another is the medication. And third is the assistive technology. And I say lifestyle because in India, you have to excuse me, the people, for various reasons, are not very sensitive of keeping them fit, and to avoid this kind of means weight is a big issue. Okay, food is a big issue. So these are the one lifestyle issues we have to really control. Then the medication, and assistive technology comes into the play on the very beginning. not to allow any deformity to happen. Once deformity starts happening, assistive technology role goes downwards. Okay? Then ultimately people have to go for surgery. But if it is in the early intervention is the key. Early intervention, proper medication, and proper health promotion, especially the diet and the physical activity. This can really control this issue. You know, I've been to many houses. They have everything, but they don't have a weighing machine at their bathrooms. You'll hardly find any bathrooms here without a weighing machine. And every morning or every weekend, we check our body weight. So even if I see my next generation, my children and all, they all are so conscious about their health and their diet. So once you start acquiring those, it's very difficult to stop it. So we have to see that how to save ourselves from those and try to see that when it happens, how we can tackle it at a very early stage, not when already there is a lot of deformity. You have to excuse me if I have no intention to offend anyone, any race or anything, but this is my personal experience. That's what I'm sharing.
Thank you, sir. The next question is from Ritu Ghosh. Do you think even in medical education, introduction to assistive technology should be included? What is your experiences in other countries?
What I learned, the course curriculum of any institute or any discipline is the most difficult to change. It's sometimes more difficult than Bible or Quran or Gita maybe. People, this is a holy thing, you know, so we have a very mixed luck, but we are seeing that lot of interest now coming. So now the continued medical education is creating more opportunities to learn this kind of a new things. So we are hopeful that with the need, as previous participants said, that with the need, things will change. So we have not made much progress at this stage, but we are positive that change will happen. And it has to change because we are no more in 20th century. But you ask many people, when you change your course curriculum last time, and you will find the answer. This COVID, take example of COVID. COVID has derailed all our thinking, how the health service should be provided. So if I wait another 5-10 years for my curriculum to change, to respond to COVID, it will not work. iPhone doesn't wait 5 years to come with a new phone, right? Every year or 2 years, they come with a new model, new version, new software. Technology is going much, much faster pace than the health science, traditional health science. So we have to really catch up. We have to do a lot of work to be at par and to be ahead of the curve so that no condition can threaten us. And we have to see that health care becomes essential and more budget GDP allocation for the healthcare so that everybody has a universal access to the health.
Thank you, sir. The next question is from Girish Kempaya. How soon one can expect the assistive technology could reach primary healthcare centers in developing countries like India?
It's very difficult for me to answer because it's the Ministry of Health or Ministry of Social Justice in India has to take that call. They have to take that call. But we would be very happy to partner in this process, partner in this journey. Keep it in mind that we are working with ICMR, Indian Council of Medical Research. We are working with CMC Vellore. We have some partners here and there. So, but what you said has to be part of the mainstream policy decision. And only Ministry of Health or Minister of Social Justice and Empowerment can take that decision. And if they take that decision, if they need any technical support, WHO would be more than happy to provide that. That's where we are.
Thank you, sir. The next question is from Nishchita R. Rao. There are a lot of confusions on who exactly has to prescribe an assistive device, and also our country lacks in standardized protocols regarding assessment or prescription and follow-up. What are the ethical concerns about this?
Yeah, and that's again has to be decided by the professionals. In India, there is a Rehabilitation Council, Medical Council, and there is another council, Health Council. They have to really make a call on this. In India, is like many other countries, are very hierarchical. In many countries, these decisions are quite decentralized. So somewhere it is a multidisciplinary, somewhere even the nurses can take a decision or prescribe, but there is a ceiling, there is a limit. So the simpler, what we are trying to see, that generalists like nurses or allied, they can take decision on some basic assistive devices, like a walker, crutches, stick, like that. Maybe some allied health professionals or paramedicals like physiotherapy, occupational therapy, they can take a decision up to certain level, or the doctors. But after beyond certain level, it has to be the specialist or the multidisciplinary team. But in many countries, they divide it into the, if you look at my slide, what I said in one of the slide in the 18 provision system, here, if you look at this simple, frequent, what can be done at the local level, community level, usually they prescribe and their prescription is approved by the government, because many specialists, many doctors don't exist there. So as the products becomes complicated, more difficult, require more higher level of skills, and the cost, it goes much higher level. So this again has to be decided by the council, whoever is responsible for bringing the ethics and regulations on the provision, prescription, and reimbursement. We hope that gradually these products will come under the medical health insurance, and only when it comes under the medical health insurance people will get tighter and they will demand, and that might influence the change. But good question, very happy, and we really see that is very much needed.
Thank you, sir. I think maybe those who are having apprehensions about prescription of assistive devices and all, I think we can lay down the SOPs, since the new council is being formed at the central government. Government of India is planning to come out with a new council. Maybe these guidelines can be sent by professionals to the government and give their representative. We have next question from Jagdish Pandey. Is WHO planning any training program to train professionals to understand the importance of assistive technology in developing countries?
Okay, I have just an addendum to the previous speaker question, is also what we are trying to see, that many of these products are also sold over the counter by anybody. So many people go to all the centers or the pharmacist or druggist shop, usually opposite to the big hospitals, and doctor prescribe wheelchair. They buy a wheelchair and nobody knows what wheelchair it is, because the pharmacist community, which is a big community, is not, assistive technology is part of their course curriculum, but they sell most of these products. And many people who even don't have a pharmacist license also sell these products. So as a result, they sell the crutches. So my auntie had a right side hemiplegia, but they have given a tripod for the left side. So even this simple knowledge do not exist, and the people or the companies who are producing these products, they don't explain what these products, what are the minimum care, what is the minimum measurement, what are the safety issues. So many people, they fall when they have a wrong crutches and nobody trained them how to use the crutches. So they collect these crutches from the store, come to home, try and fall, get admitted in the hospital next week for the hip fracture. So this is why the knowledge has to come. And this is where you have to see that these are a little bit more educated and regulated so that people don't have further problem. So now coming to the next question, that, WHO is not a training institute. We are talking about starting a WHO academy. And in France, we have a big project. So WHO Health Academy, which is going to start next year. We are in the pipeline. There is a lot of competition, but we are in the pipeline to put this in the courses which WHO Health Academy will conduct. So if we are lucky, then we'll get it through next year, if not year after. But that doesn't stop any universities and others to do it, because we have quite a bit of ready-made materials to give you to do it.
Thank you, sir. I think those physiotherapy senior faculties who are participants in this program, plus the Board of Studies chairman and Mobility India, can sit together and come out with a diploma, postgraduate diploma, or something like that in assistive technology. It will be more helpful to our students, and this can be a good thing to do on a silver jubilee occasion of Rajiv Gandhi University of Health Sciences. I think I request everybody to sit together and come out with a plan so that we can start off this program at the earliest. If there are no questions, we will wind up this session today. And I thank Mr. Khasnabis for taking your time off from the schedule and coming to be with us and enlightening us about assistive technology. I'm sure many physiotherapists would be now keen to look into what is assistive and technology and how we can go about it. We will have more takers for assistive technology and more people to guide those who need information also. Hopefully by next 2-3 months, we'll come out with a program also in assistive technology. Thank you, sir. Thanks for being with us. I thank Honorable Vice Chancellor for giving us the permission to host this program. And I also thank all the faculty from physiotherapy colleges and Praveen Aron for transferring the questions from Facebook and YouTube to Zoom. I thank everybody. Thank you, one and all. Stay safe.